Hello, my name is Dr. Devinder Ramsingh. I'm Director of Clinical Research and Perioperative Ultrasound with the Department of Anesthesiology at Loma Linda University Medical Center in Loma Linda, California. Today I'd like to talk to you about the concept of point-of-care ultrasound, with a particular emphasis on how point-of-care ultrasound can be useful in the perioperative setting. Well, just for some background to this topic, let's look at what the primary tool most healthcare providers use to evaluate the patients, the stethoscope. The stethoscope was invented in 1816 by Dr. René Laennec from France. And it's very interesting to think about the fact that while so many other industries have advanced with different modernization and incorporation of technology to improve their everyday practices, the stethoscope still remains the pinnacle point-of-care examination tool used by most healthcare providers. So just for some analogies here, we've gone from the horse and dune buggy to cars that essentially can drive themselves. We've gone from the notepad to the iPad. Yet, despite all these modernization and incorporation of technology into these industries, the stethoscope has remained the primary bedside assessment tool used by most healthcare providers. In fact, really the only advances we've been able to develop is the ability of digital recording and amplification techniques. Insert the concept of point-of-care ultrasound, which is really the idea of using the advancement in ultrasound imaging to improve our bedside assessment in a point-of-care manner. And really it has to go with the idea of changing how we view ultrasound imaging. So still, commonly, ultrasound is viewed like something like this: a large device that is often confined to certain imaging laboratories such as cardiology or radiology and obstetrics, requiring a special technician to take it to the patient's bedside, requiring formal ordering and test because of the fact that it's such a limited resource. Well, recent advances in ultrasound technology has allowed this device to become much more portable, much more smaller, much more cost-effective than what has previously been available. And all of this allows us to be able to use ultrasound technology by more providers in a true point-of-care bedside manner. And that's the idea of point-of-care ultrasound. It refers to the use of these portable ultrasound technologies. For example, now there are laptop systems that exist, and even handheld devices that exist. Again, using these modernization of ultrasound imaging technology to improve our bedside assessment for both diagnostic and therapeutic purposes. Kendo et al. Actually defined point-of-care ultrasound as portable ultrasonography that's brought to the patient and performed and interpreted real-time by that same provider. It is meant to be an exam that has a well-defined purpose linked to improving the patient outcome. It should be focused and goal-directed, and again, quickly performed at the patient's bedside. Really what we're talking about here is the incorporation of ultrasound into our physical examination strategies. This concept of point-of-care ultrasound has been embraced by many societies and several specialties to a large degree, particularly in the critical care environments and emergency medicine room environments. Yet for the perioperative setting, the support and literature to show the utility of point-of-care ultrasound is lacking. And this is interesting because of the fact that when you think about the situation of acute care medicine and the fact that the perioperative environment is very similar to emergency medicine and critical care environments, in particular with what acute care events can happen in any of those settings, I would argue that the perioperative environment is exposed to all the similar pathologies as well as acute care situations as the emergency medicine and critical care environments. In addition, since the patients that we're taking care of, their pathologies, are in a constant state of flux, whether they're going from the emergency medicine to critical care or perioperative environment, those events these patients potentially are predisposed to having can happen at any point in the continuum of those settings. Since all of those are reality, again, since the pathologies that our patients are presenting with and the acute care events, for example, myocardial infarction, pulmonary embolism, or pneumothoraces, all of these kinds of both pathologies and acute care events can happen in any of these patient care settings. And so why should the skill set of that healthcare provider change simply because they're in a different level of the hospital or environment? So again, the bedside assessment techniques, why should they change in any acute care setting by simply going from the emergency medicine room to the operating room or from the critical care room to the operating room. Again, I'd argue the fact that all of these environments are very similar into what pathologies and acute care events can occur. So again, why should our bedside assessment change simply because somebody's going from a different floor in the hospital? Well, let me give you an example of the utility of point-of-care ultrasound for the perioperative setting. This is actually one of my first cases of incorporating point-of-care ultrasound in the perioperative setting. This was a 45-year-old female with a past medical history of lupus who was scheduled to have an ORIF of her ankle and distal tibia. This was secondary to a recent MVA. Really, the only past medical history that we knew about the patient was a questionable history of lupus. She wasn't on too many medications. Her initial evaluation was done at an outlying facility, not at the main emergency medicine room. Because of that fact, the notes were limited for this patient. But nonetheless, this is the story that the primary anesthesia team received, that she had this, was instructed to be non-ambulatory, but actually because of the fact that she was not compliant with being non-ambulatory, she worsened her injury. So that was the story that the primary anesthesia team received, that the patient was having surgery secondary to non-compliance to being non-ambulatory. But when the primary anesthesia team came to evaluate the patient on the day of surgery, they actually got a very different story from the patient. The patient actually reported to the team that it wasn't because of the fact that the patient wanted to be non-ambulatory and go against what had been recommended to her. It was actually because of the fact that the patient had become so short of breath. She'd actually just simply wanted to get to the side of the bed to try to support her breathing. And in that process of trying to move over to the side of the bed, she fell and worsened her injury. And that story was very at odds to what the primary anesthesia team had heard previously. And at that point, they were trying to risk stratify what to do next. We talked about the idea of evaluating her by using point-of-care ultrasounds to see if we could figure out a mechanism for why she had become so short of breath since her injury. So we performed a cardiac point-of-care ultrasound examination. And even if you've never seen a cardiac ultrasound before, you can notice that there's a large amount of fluid outside of this cardiac structure. And anytime you see a cardiac sort of beatboxing and doing some sort of strange dancing in a big area of fluid, that is of concern. And so this is somebody who had a very large pericardial effusion. And we were the team that actually was able to appreciate this for the first time because, again, her history was not clear into what potentially could have been occurring to her. So this was one of my first situations where we showed the utility of point-of-care ultrasound. This patient had therapeutic strategies to improve this effusion before they had their operation and did very well. And again, the idea of point-of-care ultrasound is to help with these sort of acute care events and situations. We're not meant to change formal diagnostic imaging. We're simply trying to improve our bedside assessment of our patients. So one more time, what is point-of-care ultrasound? Well, again, it's the utilization of modern technology to improve our physical examination and bedside assessment techniques. And again, I want to highlight and emphasize the idea of incorporating this concept into our physical examination strategies. Really, it's not meant to be a replacement to formal diagnostic imaging. Rather, again, it's simply just to improve our bedside assessment of our patients, to facilitate earlier diagnosis, to shorten the time period for that, and again, facilitate management of those acute care events. We really should be viewing this as just any other monitoring device or tool designed to improve perioperative care and management of our patients. So actually, the AMA has actually come out and supported this concept of point-of-care ultrasound, again with the idea of improving our bedside assessment or improving our physical examination technique, and actually has passed several resolutions stating that all medical specialties have the right to use ultrasound in accordance with their specialty-specific practice standards. So they did put it back on those specialties to do further development, and I'm very excited to present further in this talk on potentially where we're showing utility in the perioperative environment. But again, fundamentally, how we should view point-of-care ultrasound is just like any other tool in the perioperative setting. So for example, we have techniques and technologies available now that provide assessment of our patient's cardiovascular status, providing things such as their cardiac output and stroke volume. We have other tools now associated with our anesthesia ventilators that allow us to have real-time spirometry on our patients and flow meters to evaluate sort of pulmonary function status. Well, really, we're talking about how ultrasound now can be used just as any of these other tools and techniques that have been developed and shown to be useful in the perioperative setting. It's really just adding on ultrasound in that same manner. And again, I mentioned the fact that many other specialties outside the perioperative arena have already embraced perioperative point-of-care ultrasound. So we can notice that there's a disconnect. And in fact, if you rewind back to approximately 10 years, 2007 to 2010, really more and more the development of point-of-care ultrasound had been emerging in the critical care emergency medicine room settings, but there was a disconnect between potential utility of POCUS or point-of-care ultrasound in the ER and ICUs from the demonstration of its utility in the perioperative setting. So this is the moment when myself and other team members decided to evaluate the potential utility of perioperative point-of-care ultrasound. And I'm excited to tell you some of our research. So in 2010, we developed a perioperative point-of-care ultrasound and education curriculum with the idea of evaluating how we can use point-of-care ultrasound to improve perioperative care. And so we sought off to form a task force to develop this comprehensive point-of-care ultrasound curriculum, but again, focused for the perioperative setting. So we developed this task force incorporating, again, the other specialties that had already demonstrated utility of point-of-care ultrasound, particularly critical care emergency medicine, task force of anesthesiologists, simulation experts, since the literature had supported the utility of simulation and hands-on training to improve ultrasound education. We also wanted to evaluate potentially our surgical colleagues as well to improve how the perioperative environment could get improved with the incorporation of a point-of-care ultrasound curriculum. And ultimately, we came up with a curriculum that we abbreviated as the Foresight curriculum. How did we come up to the topic of the curriculum? We also surveyed multiple different types of perioperative providers, including all the program directors. The slide you're showing here is just a snippet of one of our surveys where we surveyed program directors across the United States to evaluate their embrace and idea of point-of-care ultrasound. And specifically, we asked them two questions. First question we asked is, what did they receive training on when they're a resident? And these are just a snippet again of some of the point-of-care ultrasound topics. In total, we had identified approximately 50 point-of-care ultrasound topics that existed at that time in 2011. And we wanted to evaluate which of those 50 had the program directors in the United States received some education on. And you can see the big ones that are fairly intuitive, central venous access and transesophageal echocardiography, along with regional, were the main topics that people had received education on during the residency training. But then when we asked them, well, what topics do you actually think would be useful for the perioperative setting? We saw a marked change in their responses. So we saw a lot of topics that these folks had identified to be useful in the perioperative setting or potentially useful for the perioperative setting, but these were also topics that they had not received formal training or education on during the residency. And it was those topics that we identified to establish our curriculum. So ultimately, it was a 21-point curriculum that focused on the key 7 topics there of cardiac, pulmonary, hemodynamic, abdominal, airway, vascular access, and intracranial pressure assessments. And again, we abbreviated the examination as the Foresight, perioperative ultrasound examination. Foresight stands for Focused Perioperative Risk Evaluation Sonography involving gastroabdominal, hemodynamic, and transthoracic ultrasound. And you can see in this cartoon here all the different topics that we incorporated into this examination and curriculum. So we sought out to evaluate the utility after we established these topics by developing an educational strategy to educate perioperative providers on these concepts. And again, listed here are the main topics that we focused on for the perioperative or towards anesthesiologists. We wanted to also evaluate that what the clinical impact of implementing a training program on patient care, how that would occur. So again, we had 3 objectives here to demonstrate the utility of this curriculum, indicate these topics being relevant for anesthesiologists, and then demonstrating the clinical impact of folks after they receive this training. This ultimately was published in September of 2015 in the Journal of American Society of Anesthesiologists. So for 2 years, we developed a curriculum that was a 6-month curriculum, but it cycled a total of 4 times from August 2012 to 2014. We had different types of tests on a 6-month period, including hands-on model examination. And we also allowed our residents to receive additional pathology training to see if that improved their learning as well. All of these curriculum topics now can be found on the website, foresiteultrasound.com. And when we wanted to evaluate the level of impact for evaluating the utility of this educational strategy, we used the Kirkpatrick level of evaluation. And our primary outcome was to assess for potential clinical impact after folks had received training on the foresight examination. Secondary outcome markers were overall just satisfaction surveys, which is the Kirkpatrick level 1, assessment of curriculum content, and the hands-on training examinations as well. I'll just briefly highlight some of the results of this study. The residents went through this curriculum. This was at a single site, provided a high level of satisfaction with the concept and the topics. We demonstrated that content retention was dramatically improved after going through the curriculum, and that once with the incorporation of simulation and educational strategies that we had incorporated, our particular course had a very structured manner in which half of the lecture was didactic and the other half was hands-on training with either a model or a simulator. And that strategy was proven to be effective to improve a patient's image acquisition techniques and timing to identify various structures over the 2 years of the study. Now I really want to focus some more time on what our primary outcome marker was, which was, again, the clinical impact. So after I mentioned the fact that this study was performed for a 2-year period from 2012 to 2014, we wanted to evaluate, after a year of training through the department, how clinically useful was this educational strategy. So we started documenting the point-of-care ultrasound examinations that were performed in folks who had gone through the curriculum and had received a certification through the department of having achieved 50 complete foresight examinations. So with those criteria, afterwards we had evaluated a total of 224 point-of-care ultrasound examinations that were performed from this time period here. You can see that the majority of these were performed in the operating room, followed by pre-op and the post-anesthesia care environments, as well as some outlying areas. Interesting to report that the main trigger for point-of-care ultrasound examination was the patient's past medical history being something that was worrisome to the primary anesthesia team, followed by hemodynamic instability, respiratory failure, facilitation in the location of the endotracheal tube, and then peripheral venous access. When we surveyed the primary anesthesia team on whether or not they found the point-of-care ultrasound exam that we provided to be useful in impacting their anesthetic management, they reported at a rate of 76% of the time to actually report that our findings actually altered their management strategies. When we asked specifically as to why their management changed, 31% of the time it was secondary to us developing a new diagnosis, 45% of the time it was verifying the current known history of the patient, and 24% of the time it was simply just aiding by confirming normal findings. This is just a graphical breakdown of the different types of examinations we performed. Cardiac was the most frequent examination performed, both in number of exams performed as well as the number of new diagnoses developed, followed by pulmonary and then abdominal, and peripheral venous access was also shown to be useful to the primary team as well, and endotracheal tube and intracranial pressure assessment. So hopefully that sort of overview of that research project that we were involved in highlighted the fact that the incorporation of a perioperative point-of-care ultrasound education curriculum was useful to anesthesiology residents. And when we used a model simulation guided strategy and took the time to evaluate their training and have a departmental certification process, when you went through those steps and then evaluated the clinical utility, there was some suggestion that the incorporation of point-of-care ultrasound for the perioperative environment after receiving, again, the appropriate level of training, was useful to improving perioperative care. So that was 2014. Where are we today? Well, now there's several societies through anesthesiology that have now incorporated workshops in the concept of point-of-care ultrasound. Both American Society of Regional Anesthesia as well as the Society of Cardiovascular Anesthesiologists now host workshops on this topic. There's other workshops that exist on the idea of point-of-care ultrasound education, particularly with the emphasis for perioperative and acute care settings. And more literature now has been developed to support its utility. Recently, Canty and Cowie both have demonstrated that general anesthesiologists can be trained in basic cardiac ultrasound, and when they are trained, they can positively impact perioperative care management decisions by allowing, again, their ability to assess acute cardiac physiology and pathology. Other areas and examination tools have been developed to facilitate the perioperative environment. Adler et al. Actually published a pause examination protocol, which incorporated the topics of cardiac, volume status, and pulmonary to facilitate the evaluation of hemodynamic instability, again, with the focus being in the perioperative environment. Zimmerman et al. Recently published in a issue devoted through ANA on the concept of cardiovascular and pulmonary ultrasound. Ford et al. Recently published on the utility of point-of-care ultrasound to detect perioperative acute pulmonary pathology, such as atelectasis, pleural effusion, and pneumothoraces in patients undergoing cardiac surgery, again showing the utility of point-of-care ultrasound with a particular focus on pulmonary pathology. Perales et al. Has demonstrated through a variety of studies on the utility of point-of-care ultrasound and the perioperative environment to evaluate for gastric content for both emergent and non-emergent cases. Haskins et al. Has also published on the concept of abdominal ultrasound to be useful in the perioperative setting as well. And finally, the utility of point-of-care ultrasound to detect appropriate location of the endotracheal tube has also been demonstrated and has actually been shown to be far superior than traditional auscultation. This is that article published here. And editorials actually have been popping up more and more in this space for the perioperative setting, where, again, the idea of questioning that the stethoscope will always remain a primary point-of-care assessment technique, but is the utility of ultrasound growing such that we should really incorporate more and more for the perioperative bedside assessment? In fact, recently a call to action has been published on the idea of this incorporation of perioperative ultrasound to all anesthesiology trainees. So in conclusion, hopefully we've spent a significant period of time on highlighting the utility of perioperative point-of-care ultrasound, and I'd like to highlight further about going back to Dr. Renee Leineck shown here. So this is a picture of what, prior to the stethoscope shown here, the common way of physical examination, where the healthcare provider actually would take their ear and place it on the patient's body to auscultate for different pathologies. And it was actually Dr. Leineck's motivation of essentially not wanting to evaluate his patients this way to develop the stethoscope. And I'd just like to show you what's shown here, what he developed. And the key thing I'd like to highlight is that he not only did he develop the technology, but he developed a method in which we could educate on how to use that technology. So he published his findings and his use of this technology, and that has been actually one of the most widely translated works in medical literature. But in that process, this is actually from the English translator who was incorporated to or supported to translate the works by Dr. Leineck, and this is what they had to say. This was published in the Times of London in 1834, reporting that although it seemed that technology was useful, they doubted whether or not it would actually be incorporated into everyday practice, simply because of the fact that it was often viewed as too foreign and opposed to what the natural habit and the current state of practices were for physicians at the time. And I want to bring this up because even then you can see how the stethoscope was questioned on how it could change what had at that time been the point-of-care examination technique of standard, which was again putting the ear on the patient. Are we at the same situation now with ultrasound? is ultrasound potentially the next step of allowing us to be able to evaluate our patients by not only hearing but seeing pathology? And again, I'd like to talk about the fact that technology is one of those things that hindsight always demonstrates its utility, but we really have to take the time to evaluate it now as the technology is in front of us. So finally, hopefully we've talked a lot about the utility of point-of-care ultrasound and how potentially it could be useful for the perioperative environment. And I'd like to encourage the fact that anesthesiology and perioperative setting itself has a long history of developing and dramatically altering practice standards with the incorporation of technology. And the potential of ultrasound to just do a similar process as we've done similarly with so many other technologies does exist. And really, I'd like to emphasize that perhaps it is now time for our specialty to embrace point-of-care ultrasound alongside our other acute care specialty colleagues to provide a higher level and quality of bedside assessment for our patients. Thank you very much for your time. I'd like to encourage everyone to evaluate more on this topic on the Sonosite website shown below. Thank you again.